I think now we have to introduce the star of the day, of the session, Dr. Kamal Bandhu Kapur. Please, sir.
Okay. First of all, I'm usually known more for my surgical presentations and videos, and this is a little offbeat, but for people who don't know, I have a quirk for physics and mechanics and computers. So though actually this topic is up my alley, but I'll be talking more about the optics. This topic was slowly slipped into my pocket by Johnson & Johnson guys, and if you realize my name was slipped at the last moment, I did get up and make some fresh slides early in the morning, 6 o'clock, along with some of the slides given by them. So I'll be talking more of enhanced monofocals, and for my colleagues here, my 83% of practice over 2 years has shifted to enhanced monofocals oblique EDOFs. We are a very, very high volume cataract surgery centers, and I have no financial disclosures about any of the products I'll be talking here. Now the best part is the presbyopia we create for our cataract patients is the iatrogenic presbyopia. So we've been through the monovision, bifocal, trifocal, swing set, pinhole lenses, and now probably the EDOFs and the enhanced monofocals. So the question is, are the enhanced monofocals or the EDOFs, are there the missing links to taking care of the presbyopia? So this presentation is actually going to address that. Now, what is daily intermediate vision? I will not spend more time on that. We all are spending more time on our mobile phones and computers rather than doing stitching, needling, or doing very, very close work. Occasional reading medicine labels or very small fonts or barcodes is very, very rare in nowadays lives. Different methods of correcting presbyopia are multifocal lenses, enhanced monofocal lenses, EDOFs, accommodative lenses, and pinhole lenses. They have different mechanism of actions, and they have different plus and minus points. So what I will be dealing here is I will be restricting my talk, though this is a part from a big talk of 1.5 hours only talking about optics and IOLs. There are some parts which I will be discussing here. So in monofocal lenses, you get the best part is you have a single point crystal clear focus. So for those who understand the defocus curve, the defocus curve peaks very high for monofocal lenses, which means you have a very pristine, clear focus. But the area under the defocus curve is not very high, which means you do not have a very large range of vision. So your depth of focus is no less, but you have a very fine and acute focus. Multifocals will have different focal points, but loss of focus in between. So you will have bumps. It's like a road with speed breakers. So you'll have bumps in between. Enhanced monofocals and EDOF lenses will have a combination of both. Ideally, these lenses will be good because they will not give you much photic phenomenon. So just for a review, a monofocal lens will give you single focus, a diaphragmatic bifocal will give you 2 focal points, and a trifractive will give you, these are the areas where there's loss of light, and there'll be slight loss. So I was a heavy user of trifocals and multifocals, which I shifted over 2 years. Simple reasons being, a lot of times you need to operate both the eyes together. They are very, very less tolerant to cylindrical powers. Capsular opacification, even a slight amount of PCO will damage the vision. Macular edemas, if any, will cause more problems. Corneal surface disorders, multifocal and trifocal lenses are very, very intolerant to surface disorders, tear abnormalities, unlike your monofocal lenses. So these enhanced monofocals are in the middle zone. They have a sweet spot. The dependency on pupil, multifocal lenses are very, very dependent on pupil. So enhanced monofocal lens will give you a depth of focus, and I will just try and explain the concept. What an enhanced monofocal lens does is it gives you a funnel of vision, and how that funnel is made, I'll explain in some optical diagrams. So the light is going over a continuous zone like a tubular cylinder. As the light focuses near the focal point on the retina, it becomes a tubular vision. So this is how it happens. So to exaggerate the concept, in a positive spherical aberrated lens, the peripheral rays are focusing before the focal point, and the paraxial rays are a little further. And in the negative, the peripheral rays are focusing behind the focal point. What happens here is, how do you get a defocus curve in these enhanced monofocal lenses is, the moment you play around with the paraxial and the peripheral rays, you get one area of confluence where both the rays are focusing and they're going tubular. This is the range of depth of focus, and this can actually be in microns, 0.2 microns, 0.3 microns, but it's enough to give the patient a depth of focus up to 50 to 60 centimeters. This is what a zone of defocus curve would be for this patient. So I've just done a simulation and made a diagram for that. So in an EDOF lens, you would have a longer range of focus. This is classical example. In a monofocal lens, if the object comes nearer, the rays will start focusing behind. But in an enhanced monofocal or an EDOF, this tubular zone of vision, even if the object comes in the intermediate range, this part of the vision will still give you a decent vision. So I call it the tunnel funnel channel of light. Thinner the channel, more the acuity, longer the channel, more the depth. But can you keep indefinitely playing with this? Why do you realize your EDOFs don't go to +3 add or a +4 add? Have you ever wondered that? There is a reason for that. The reason is, if you actually start extending this zone, there will be a zone of blur which will keep getting wider. Because both these rays are coming from side and center. So you meet them at the center point. But after that, then they diverge. So they will start diverging and create another circle. So this is how it would do. If you start extending the EDOF range beyond a point, your zone of confusion will increase like this. So as you keep increasing the dioptric power, your shadow effect will go. So that is why you will see most of the EDOFs will work between a near add of 1.5, 1.75 max. That is why you have hybrid lenses like Symphony, Synergy, because they will use a part EDOF and a part diffractive technology. So these are all the lenses I've used. I've used all of these lenses. My current favorites are iHance and LuxSmart. Use hundreds of them in my practice. So I'm talking about iHance here. It's got approximate near add of 1 + 1 diopter. That's what the literature says. But if you do a bilateral implant, so the trick I do is in my tall patients are very tall, I do not give micro nano vision. The simple reason being, a patient who's as tall as me, I'm 6 feet 2 inches, my reading length, arc length is longer, so I could do very well with an extended, like, I still don't need to wear glasses. I don't see anybody's ever seen me wearing glasses, near glasses. I'm a hypermetrope, so I just move my hand further and I can read. But for a shorter patient, I use the second myopia on my IOL master if I'm using an iHance in the non-dominant eye. So what that does for me is a 0.2 micron of defocus curve added with 0.3 myopia gives me a significant depth of nearly 1.75 add. So with these both eyes open, these patients do very well. The best part is that the surface is not pouting in the center, but the periphery is slightly different in an iHance lens. That's the best part. The surface profile of the periphery is thinner, unlike other lenses where the central part is thicker. So what this does for us is it makes it less pupil dependent, because they are not focusing on the center, they're focusing more on the peripheral, the design. So this is what happens when a pupil size is more concentrated on the center. If you have a smaller pupil, the lens will work, but if you have a larger pupil, the lens will not work. This will not happen with an iHance lens, because it's not center dominant. Also, if the decentration happens in these lenses, since the central part is not the main focal point of the lens and the peripheral part is slanting, you will not have much more photic phenomenon. So this is why I feel this lens is far more tolerant to decentrations and pupil size with least amount of photic phenomenon. I think my time is running out. I'll go very fast. So in my practice, I've seen, I'll just skip these parts, very low photic phenomenon. So who are these patients I take for these lenses are? All the patients I tell them, you want very near vision, but you may get little chance of having photic phenomenon like glare or halos, or you're okay with intermediate vision without glares and halos. Believe me, 85% of patients say, okay, sir, we don't want glares and halos. And that's how you counsel when you want to move in from your previous multifocal practice to a EDOF practice. You have to inform the patients that there is a technology available where there are no glares and halos guaranteed. So my study says, 75% patients are spectacle-free for intermediate. Near add I get for 1.25 to 1.75 diopters in bilateral. Works better in taller patients. Minimal photic phenomenon. More tolerant to surface disorders, astigmatisms, and pupil size. So conclusion is, it's a good alternative for patients who don't want to take any risk and surgeons who want to deliver excellence to their patients. Thank you.
Thank you, Dr. Kapoor, sir, for this very lucid talk. As usual, you made physics